Dear students, today our topic is ovarian neoplasm imaging. It is under section RD 1.8. Coming to the introduction, the epidemiology, ovarian malignancy is the third most commonest gynecological malignancy in India. Coming to the world, it's come to up to 6th or 7th, and it has high mortality compared to other malignancy. One of the reason is the non-specific symptoms compared to the endometrial or cervical malignancy, because this endometrial or cervical malignancy mostly presented with bleeding, but mostly this ovarian malignancy will present as a dyspeptic symptom that is not specific. So most of the stages, the diagnosis will be at the stage 3rd or 4th. And there is no lack of screening. There is lack of screening compared to the cervical malignancy, for which we have pap smear. So there is early diagnosis in stage 1 or 2, but in case of the ovarian malignancy, we will diagnose as stage 3rd or 4th. So this is the graph showing epidemiology of the ovarian malignancy. We can see in India it is coming about the 3rd, and compared to the world it is coming around 6th or 7th. Then incidence in India is about 0.9 to 8.4 in 1 lakh population. So what are the risk factors? The main risk factor is age. You can see in this image the epithelial ovarian malignancy mostly occur after 40 years, and germ cell and stromal tumor occur in the young patients. The next is the reproductive history. The hyperestrogenism due to early menarche and late menopause and nulliparity is the main reason for this ovarian malignancy. What are the risk factors? That family history of the ovarian and uterine, breast and colon cancer, genetic mutation of BRCA, then postmenopausal status, increased age. This will increase the risk of ovarian malignancy. And pregnancy, breastfeeding, use of oral contraceptive pills will decrease the risk of ovarian malignancy. So what is the approach? It is actually multidisciplinary approach with the gynecological, pathological and radiological department. So what are the clinical features? As I already mentioned, the ovarian malignancy, the symptom will be little vague. That is the one reason which is diagnosis the late stage of stage 3 or 4. So what will be the symptom? The symptom can be bloating, just pelvic or abdominal pain, urinary frequency, the back pain or fatigue or some menstrual changes. So we have tumor markers. As we know tumor markers, this is not a diagnostic, but it is mainly used for the prognostic purpose. So what are the tumor markers we mainly use? First one is the CA125, that is mainly for the epithelial malignancy. So as we know, false positive of the CA125 cancer occur in the premenstrual age group. So this CA125 we can use as a prognostic marker for the ovarian malignancy. So what are the other tumor markers used in ovarian malignancy? For the epithelial ovarian cancer, as I mentioned, it is CA125, and CEA is used for the mucinous ovarian cancer, HCG for the embryonal carcinoma, then inhibin for the granulosa tumor, and alpha fetoprotein for the endodermal sinus tumor or embryonal carcinoma. So coming to the imaging tool, what are the imaging tools we have? First one is the UST, then CT, then MRI or PET. So as you know, UST is the tool for the initial diagnosis. So what are the available? We have transabdominal scan and transvaginal scan. Transvaginal scan will more clarity about the ovarian neoplasm, like if there is any septa or any solid component, anything. So what are the morphological features we will look? We will look for the wall thickness, if the wall is irregular or not, is there any septae or papillary projection, and what is the thickness of the septae, if there is any solid component, any echogenic foci or ascites, any retroperitoneal lymph node or any deposit, metastatic deposit. So these factors we can assess in USG. So based on these factors, we can divide the ovarian malignancy to benign or malignant. For example, if in case of the malignant, wall thickness will be more and wall will be more irregular, the septa will be thick, there will be 4 or 5 papillary projection, there will be solid component which cause vascularity, and there will be ascites, retroperitoneal node and deposit. So what is the role of Doppler evaluation? Doppler evaluation, just we are seeing how much vascularity is there. It is say that in case of the malignant ovarian tumor, the vascularity will be high and there is a value called Ri which will be reduced in case of the. So as we know, we have BIRADS for the breast tumors. For ovarian tumor, recently we have ORADS, that is ovarian adnexal reporting data system. Based on this, we can divide the ovarian malignancy to benign to the malignancy, or based on that we can manage whether we need further evaluation with MRI or whether we need staging laparotomy for the ovarian neoplasm. So what is the advantage of the CT? CT, we can assess the spread usually. So in case of the malignancy, usually we use this as a tool to assess the staging of the tumor. But the problem is, compared to the ultrasound and MRI, delineation of the ovarian lesion is very less. So CT usually we use in treated patient to know the prognosis of the ovarian malignancy. Is there any spread? Then coming to the MRI, this is actually a problem solving tumor, especially if the ovarian malignancy in under USG is coming as the stage 3 or stage 4, we will do MRI nowadays with the dynamic contrast imaging. And based on that, we can assess the ovarian neoplasm. Then coming to the positron emission tomography, this is also we used for to know the recurrence and the residual lesion or any other spread and all. So in this image you can say that hotspot which showing deposit due to ovarian malignancy. So coming to the ovarian malignancy, we will divide it to primary and secondary. Primary include epithelial and germ cell tumor. Secondary include typical or atypical metastasis. So as we know, surface epithelial tumor include serous, mucinous, endometrioid or transitional or clear cell malignancy. And germ cell which can be benign or malignancy, as we know the commonest germ cell we will see in is a dysgerminoma, and in that we know LDH and HCG will be elevated. So again to teratoma which demonstrate both fatty tissue and calcification. So based on the imaging feature we can divide it as whether it's a benign teratoma or malignant teratoma. Then coming to the sex cord chomal tumor, this tumor will usually present with some case of the bleeding or some features like of androgenism or bleeding and all. So this is the granular cell tumor. It's usually present with the bleeding because of the hormone hyperestrogenism. Then coming to the fibroma, thecoma and all, these are solid tumor which usually ovarian tumors will be cystic with the solid component and all. But these tumors usually present as a solid tumors which also sometimes present with as a pleural effusion, that is we called as a Meigs syndrome. See this, you can see this in image, there is a solid lesion with vascularity, and that is the main features of these solid tumors like fibroma and thecoma. Then serotolic cell tumor, as I already told, it produces androgen. So most of the female patients show some features of breast atrophy and all. So then coming to the ovarian metastasis. Ovarian metastasis relatively common. The primary will be include gastrointestinal tract, breast, lung or contralateral ovary. Then coming to the atypical ovarian metastasis, this is actually signet ring type of the metastatic tumor to ovary. Usually it will present as a bilateral solid ovarian mass with a clear margin. Sometimes it also present as a hyperechoic solid mass with a microcyst or trabecular pattern. Thank you.